While on your rounds, you see two individuals. First up is Jenna, a 70-year-old female who presents with left hip pain after falling while getting out of bed. She sustained a fracture of the right hip, and preoperative chest x-rays reveal that she had pre-existing asymptomatic vertebral fractures before her fall. She denies any other symptoms, and physical examination was otherwise normal. Then you see Gerald, a 46-year-old male who presents with a mild but noticeable limp and hip pain on the right side after falling from a chair. Examination is unremarkable. In Jenna's case, a DEXA scan was performed revealing a T-2.8 score. In Gerald's case, radiographs of the hip showed a right hip fracture and abnormally dense hip bones. Both seem to have some type of bone disorder. But first, a bit of physiology. Bones have a hard external layer of cortical bone and a softer internal layer of spongy bone composed of trabeculae. The trabeculae are like a framework of beams that give structural support to the spongy bone. Now these are replaced every few years in a process called bone remodeling. The process has two steps: bone resorption, which is when the osteoclasts break down bone by releasing hydrogen and collagenases, and bone formation, which is when osteoblasts form new bone by secreting osteoid seam. Osteoid seam is mainly made up of collagen, and it acts like a scaffold upon which hydroxyapatite, a combination of calcium and phosphate, deposits. Bone formation requires an alkaline environment, which is why bone cells often produce alkaline phosphatase, an important marker of bone cell activity. At a cellular level, remodeling begins when osteoblasts release receptor activator of nuclear factor kappa beta ligand, or RANKL for short, which binds to RANK receptors on the surface of osteoclasts, activating them to begin bone matrix demineralization. Once there's been sufficient bone demineralization, osteoblasts secrete osteoprotegerin, which inactivates RANKL. This causes the osteoclasts to stop demineralizing the bone, and osteoblasts to secrete osteoid seam. Another high-yield concept is that the osteoblasts are derived from mesenchymal stem cells in the periosteum, a membrane covering the surfaces of bones and consisting of an outer fibrous layer and an inner cellular layer. By contrast, osteoclasts originate from hematopoietic progenitor cells, more specifically from a fusion of monocyte and macrophage precursors. These differentiate once osteoblasts secrete RANKL and macrophage colony stimulating factor, or MCSF, which interact with their respective receptors on the osteoclast membrane. Now keep in mind that parathyroid hormone also regulates osteoclast maturation, but it does so indirectly by stimulating RANKL and MCSF secretion from osteoblasts. However, its action actually depends on its serum levels. At low intermittent levels, the hormone exerts anabolic effects, meaning it promotes bone formation. Conversely, chronologically increased parathyroid hormone levels, like, for example, in primary hyperparathyroidism, cause catabolic effects, meaning it promotes bone resorption. Additionally, the hormone also increases calcium levels and decreases phosphate levels by increasing its urinary excretion. Okay, now let's talk about bone disorders, starting with osteoporosis, where there is an increased breakdown of bone mass in comparison to the formation of new bone, which results in porous and weak bones. Factors that accelerate mass loss and increase the risk of osteoporosis are low estrogen levels, as in menopause, and hypocalcemia. However, something high yield to know is that the most important factor that increases bone mass is genetics, which explains why some individuals develop osteoporosis earlier than others. Genetics is also the reason why Caucasians have lower bone densities than those of African descent. Additional risk factors include low weight, alcohol consumption, smoking, drugs like corticosteroids, which can decrease calcium absorption from the gut through antagonism of vitamin D, and medications like heparin, L-thyroxine, and anticonvulsants. Physical inactivity can also lead to osteoporosis because it causes bone deposition to decrease due to the lack of stimulation, while resorption increases. And finally, some diseases that can lead to osteoporosis include Turner syndrome, hyperprolactinemia, Klinefelter syndrome, hyperparathyroidism, multiple myeloma, diabetes mellitus, and malabsorption syndromes. Now, the two most common types of osteoporosis are type 1, or postmenopausal osteoporosis, and type 2, or senile osteoporosis. In postmenopausal osteoporosis, decreased estrogen levels lead to increased cycles of remodeling and bone resorption. This is because normally estrogen inhibits apoptosis in bone-forming osteoblasts and induces apoptosis in bone-resorbing osteoclasts. With senile osteoporosis, it's believed that osteoblasts just gradually lose the ability to form bone, while the osteoclasts keep doing their thing unabated. In both cases, bone resorption usually overtakes bone formation despite normal bone mineralization and lab volumes for serum calcium and phosphate, causing both cortical and spongy bone loss, as well as a widening of the Haversian canals, which are the canals through which blood vessels and nerves travel throughout the bone. The result is porous bones that have an increased risk of fractures. In osteoporosis, most fractures are fragility or pathologic fractures because they typically occur after minimal trauma, like falling from a chair. People with osteoporosis don't usually have symptoms until a fracture occurs, usually vertebral fractures, which are also known as compression fractures. These cause back pain, height loss, and a hunched posture. Cole's fractures, which is a type of fracture of the distal forearm, femoral neck fractures, and hip fractures can also occur, and they're often associated with postmenopausal osteoporosis and can cause limping and localized pain. Osteoporosis is usually diagnosed with a dual energy X-ray absorptiometry or DEXA scan, which tests for bone density. The test compares the individual's total lumbar spine, hip, and femoral neck bone density to that of the average score of people of similar age, which yields the result, or the T-score. A T-score less than or equal to negative 2.5 standard deviations is diagnostic of osteoporosis. A score between negative 1 and negative 2.5 means the individual has low bone density, or osteopenia. Moving on, diagnosis can also be established by a fragility fracture at the hip or vertebra in the absence of other metabolic bone disorders. One-time screening by DEXA scan is recommended in all females 65 years old and above, and in younger females with risk factors. And a high-yield fact to remember, lab values like calcium and phosphate are typically normal in osteoporosis. Treatment for osteoporosis is high yield, and it relies on bisphosphonate drugs like alendronate and risedronate. These are pyrophosphate analogs, an important component of hydroxyapatite, which help bind hydroxyapatite in bone and inhibit osteoclast activity. Bisphosphonates have poor gastrointestinal absorption, so it needs to be taken while fasting. Side effects can include jaw osteonecrosis, atypical femoral stress fractures, and if taken orally, they can cause pill-induced esophagitis, which is why people are advised to take with water and remain upright for 30 minutes after ingesting them. Bisphosphonate should also be used with precaution in individuals with renal failure, as they are excreted unchanged in the urine. Next, if osteoporosis is really advanced, teriparatide, a recombinant parathyroid hormone, can be used. Now, even though parathyroid hormone stimulates bone resorption, it's been found that pulsatile injections with teriparatide activate osteoblasts more than osteoclasts, therefore increasing bone formation. Some of its side effects include transient hypercalcemia and an increased risk of osteosarcoma, which is why they should be avoided in people with Paget disease of the bone, unexplained elevation of alkaline phosphatase, and in those with a history of cancer or radiation therapy. Thiazide diuretics like hydrochlorothiazide can be used to treat osteoporosis, especially in those with associated congestive heart failure. Hydrochlorothiazide boosts calcium retention in the distal convoluted tubules of the kidney and directly stimulates osteoblast differentiation, therefore decreasing mineral bone loss. As a downside, it can cause hypokalemic metabolic alkalosis and hyponatremia. Additionally, it can also cause hyperglycemia, hyperlipidemia, hyperuricemia, and hypercalcemia, all of which can be remembered using the mnemonic hypergluc. Finally, other medications that are commonly tested include denosumab, which is a monoclonal antibody against rank L that inhibits osteoclast maturation, and raloxifene, which is a selective estrogen receptor modulator, which mimics natural estrogen, both of which are used for postmenopausal osteoporosis. Although raloxifene has agonist effects in the bone, it acts as an estrogen antagonist in the breast and uterus, which means it can actually decrease the risk of estrogen-positive breast cancer. In rare cases, calcitonin is also used to treat osteoporosis, which works by decreasing bone resorption of calcium. Prophylaxis in those with risk factors include weight-bearing exercise and adequate calcium and vitamin D intake throughout adulthood. Hormone replacement therapy with estrogen might also be beneficial. But because hormone replacement therapy increases the risk of endometrial cancer and of cardiovascular disease, some women might benefit from adding progesterone or progestin to the treatment. Another thing you might come across is that hormone replacement therapy, just like pregnancy and oral contraceptives, can increase thyroid binding globulin or TBG levels. TBG is the protein through which thyroid hormones circulate in the plasma, so its increased levels also lead to increased total T4 and T3 levels. However, because the bound form of thyroid hormone is biologically inactive, and because the level of free thyroid hormones remains within normal limits, the affected individuals remain euthyroid. Next, osteopetrosis, which means stone bone, is a rare genetic disorder that makes bones abnormally dense due to a decrease in bone resorption. The condition is associated with mutations in at least 9 genes, like the one for carbonic anhydrase 2, which impairs the ability of osteoclasts to generate the acidic environment necessary for bone resorption. Without functional osteoclasts, old bone is not broken down as new bone is formed. As a result, bones throughout the skeleton become unusually dense and structurally abnormal, making them prone to fractures. Symptoms of osteopetrosis depend on the severity of the disease, and depending on which genes are affected, there are 3 types of disease that can occur. Osteopetrosis tarda, the adult form, which is benign and asymptomatic; osteopetrosis congenita, and marble bone disease, the infantile forms, both of which are severe. Osteopetrosis congenita is associated with failure to thrive and growth delay. When skull bone tissue grows excessively, it can narrow the cranial foramina, an opening on the skull base through which many cranial nerves pass, and cause symptoms like proptosis, which is protrusion of the eyeball, blindness, deafness, and hydrocephalus, which is cerebrospinal fluid accumulation within the brain ventricles. When bone tissue begins to replace bone marrow in the medullary cavity, it can cause severe bone marrow failure, resulting in pancytopenia. Consequently, people with severe osteopetrosis are at risk of abnormal bleeding due to thrombocytopenia, anemia, and recurrent infections caused by white blood cell depletion. Now, the body tries to compensate for bone marrow failure by stimulating extramedullary hematopoiesis in the liver and spleen, resulting in hepatosplenomegaly and hypersplenism. Unfortunately, it can't really keep up with the body's demands, and as a result, these individuals die due to severe anemia, bleeding, and infections. Marble bone disease is not characterized by bone marrow failure, but there can be renal tubular acidosis because carbonic anhydrase 2 is also involved in many kidney functions. Additionally, the affected individuals might have a short stature and present with intracranial calcifications, hearing loss, dental abnormalities, seizures, and psychomotor impairment. Diagnosis is established by X-ray, which most often detect abnormally dense bones and narrowed medullary cavity. Some specific signs that can appear include diffuse symmetric sclerosis, causing the classic bone-in-bone appearance of the vertebrae and phalanges, where there's an even radiopaque area surrounded by a trim of radiolucent tissue, and sclerosis of skull base, pelvis, and vertebral end plates, giving rise to sandwich vertebrae, where the superior and inferior margins of the vertebrae are opaque and the middle radiolucent. Lab tests can show thrombocytopenia, anemia, decreased calcium, and elevated serum acid and alkaline phosphatase levels. It might be good to know that alkaline phosphatase is the biochemical marker of osteoblast and osteoclast activity in the blood. However, it can come from other sources too, like the placenta, liver, and intestine, which means it's not highly specific for bone cell activity. In these cases, electrophoresis and monoclonal antibodies can be used to determine the source of alkaline phosphatase. And finally, in addition to the routine laboratory investigations, genetic testing should be undertaken in all individuals with suggestive symptoms of osteopetrosis. Osteopetrosis tarda doesn't usually warrant any treatment except for fragility fractures. Infantile osteopetrosis, on the other hand, might benefit from childhood bone marrow transplant, which is potentially curative as osteoclasts are derived from monocytes. Symptomatic treatment can also be provided, ranging from treatment of fragility fractures and erythropoietin for any associated anemia to corticosteroids to alleviate both the anemia and stimulate bone reabsorption, and vitamin D to stimulate dormant osteoclasts and stimulate bone reabsorption. Next, Paget disease of bone, or osteitis deformans, is a disorder where there is abnormal bone remodeling that happens in either some regions of a single bone or the whole skeletal system. Most often, it involves the skull, lumbar vertebrae, pelvis, and the femur. Now, the exact cause of Paget disease of bone is unclear, but it can get triggered by infections, especially with measles virus, and it's also linked to genetic mutations like the SQSTM1 mutation, which encodes a protein involved in regulating osteoclasts. Okay, so there are three main phases to the disease, which might pop up in your exams. Phase 1 is the lytic phase, and that's where osteoclasts, which in Paget disease are large and have over 100 nuclei, start to aggressively demineralize the bone up to 20 times more than normal. Phase 2 is the mixed phase, and that's where the lytic phase occurs alongside the blastic phase. In the blastic phase, there's a rapid but relatively disorganized proliferation of new bone tissue by an unusually large number of osteoblasts. The result is that collagen fibers are deposited in a haphazard way. Phase 3 is the sclerotic phase, and that's where new bone formation exceeds bone resorption, and the final result is bone that's structurally disorganized and therefore weaker than normal healthy bone. At the same time, vascularization of the sclerotic bone increases as well, mainly because osteoclasts seem to secrete cytokines that activate fibroblasts and endothelial cells proliferation, which induce new blood vessel formation. Eventually, the osteoblastic activity also slows down, and there's a dormant state in the disease called the burned out state, which is sometimes referred to as the quiescent phase. Early on, Paget disease of bone doesn't typically cause symptoms, but over time the misshapen bone can impinge on nerves and cause bone pain. In addition, if the skull is involved, the overgrowth of bones can make a person have a lion-like face, which is called leontitis. And because the skull is larger, the affected individuals often say that they need a bigger hat. The bony overgrowth can also narrow the auditory foramen and impinge on the auditory nerve, leading to hearing loss. If the optic nerve is compressed as it passes through the optic canal, there can be vision loss. Sometimes, the accelerated bony growth can lead to genetic mutations that cause a bone cancer called osteosarcoma, which in this case is called Paget sarcoma. Other bony deformities from Paget disease of bone include kyphosis, which is an excessive curvature of the spine, making a person face down to the ground, lower limb muscle weakness from misshapen vertebrae compressing the spinal cord, and pelvic asymmetry. It can even lead to bow legs if the tibias and femurs get too weak to support the person's weight and begin to bend over time. If the parts of the bone that are involved in the joint are involved, it can result in arthritis. Although cardiovascular involvement is uncommon, those with widespread Paget disease and extensive hypervascularization of the bone marrow can present with an arteriovenous shunt, leading to high output cardiac failure. The diagnosis of Paget disease of bone is usually made via blood tests, which can present with elevated levels of alkaline phosphatase, which gets released into the blood as bone is destroyed, with normal calcium, phosphate, and parathyroid hormone levels. In addition, an X-ray scan might show the mosaic pattern that's characteristic of Paget disease of bone, which consists of radio-opaque and disorganized areas of sclerosis, interspersed with lucent and more normal bone. Long bone chalk-like fractures might also occur, which are clean fractures that look exactly like a piece of chalk broken in two. Finally, keep in mind that a bone biopsy is usually done to exclude malignancies, which can mimic some of the findings of Paget disease of bone. Typical findings include haphazardly oriented collagen fibers that create a mosaic pattern. Treatment of Paget disease of bone includes pain relief medication as well as anti-resorptive medications like bisphosphonates, which slow down the bone lysis. In addition, surgery can help correct bone deformities, decompress an impinged nerve, and reduce associated fractures. Now, inadequate bone mineralization manifests as rickets in children and osteomalacia in adults. Inadequate bone mineralization can be due to a deficiency or impaired metabolism of vitamin D, phosphate, or calcium. When these elements are missing, osteoblasts don't have enough calcium and phosphate to deposit into the organic matrix. In children, because the growth plates haven't closed yet, this leads to cartilaginous growth plates, softening of the bones, impaired growth of bones, and bone malformations. Whereas in adults, where the epiphyseal plates have already closed, it only causes defective mineralization of osteoid, resulting in weakening and softening of bones, which makes them easier to fracture. Okay, now vitamin D deficiency is the most common cause of both rickets and osteomalacia. Often it occurs in those who aren't exposed to enough UV light since UV stimulates vitamin D synthesis. This is especially true for those who have recently immigrated from an area with a sunny climate. Other causes of vitamin D deficiency include intestinal malabsorption, which can be seen with celiac disease or Crohn's disease, and users of medications like phenytoin, an anticonvulsant that's metabolized by the same liver and kidney hydroxylase enzymes that's needed for the synthesis of vitamin D. So it makes sense that another cause of vitamin D deficiency is liver and kidney disease. For example, rickets or osteomalacia can occur in chronic liver disease due to the liver's inability to turn inactive vitamin D into 25-hydroxyvitamin D. The same goes for chronic kidney disease, where the kidneys can't turn 25-hydroxyvitamin D into 1,25-hydroxyvitamin D. Both conditions result in an active vitamin D deficiency, which leads to impaired bone mineralization. With both rickets and osteomalacia symptoms include diffuse bone and joint pain, proximal muscle weakness, bone fragility, and increased risk of fragility fractures. Because of low levels of calcium, there may also be muscle spasms and numbness. Rickets-specific symptoms include thin, soft skull bones, which is caused by craniotabes, delay in the closure of fontanelles, and bow legs, also known as genu varum. There may also be an enlarged prominent frontal bone. Additionally, rachitic rosary can be seen, which are little bumps that appear along the chest wall due to the widening of the junction between the ribs and costal cartilage in front of the rib cage. Now, those with severe vitamin D deficiency might also present with symptoms of hyperparathyroidism, like weakness, depression, confusion, and increased urination. The parathyroid gland increases in size since it needs to secrete more parathyroid hormone as a result to low vitamin D and calcium levels. Rickets and osteomalacia are usually diagnosed with lab tests, which show abnormally low vitamin D levels in blood serum, low blood calcium, and elevated serum alkaline phosphatase. As a result of low calcium, there may also be high PTH, which may also lead to low serum phosphate. Now, X-ray imaging of rickets and osteomalacia might show signs of decreased bone mineral density or osteopenia. First, there's looser zones, which are bands of low bone density that form on the surface of the bone, and they look a bit like bone fractures, so they're also called pseudofractures. Looser zones frequently develop in the anterior and superior pubic rami of the pelvic bone. In rickets, an X-ray image of the wrist and long bone metaphysis might show metaphyseal cupping and flaring. With metaphyseal cupping, the edges of the metaphysis widen laterally like flared jeans, and the metaphysis itself drops inwards, towards the diaphysis, which makes it look a bit like a cup. Another X-ray finding in rickets is metaphyseal fraying, where instead of the metaphyseal surface appearing smooth, it appears fuzzy and irregular. Treatment for both rickets and osteomalacia involves oral vitamin D supplementation and treating the underlying cause, which could be any condition affecting the organs responsible for vitamin D activation. In addition, preventative measures include vitamin D supplementation during pregnancy and administering vitamin D drops to neonates and infants, especially those who are breastfed. Alright, as a quick recap. Osteoporosis refers to decreased bone density due to increased bone resorption compared to bone formation, resulting in porous bones with an increased risk of fracture. There are many risk factors, including decreased estrogen levels, physical inactivity, and smoking. Osteopetrosis is a genetic disorder that causes an increase in bone density secondary to osteoclast dysfunction. In adults, it is mostly asymptomatic, but it can cause fragility fractures. In children, it can lead to bone marrow failure, nerve palsies, failure to thrive and grow, hepatosplenomegaly, and renal tubular acidosis. In Paget disease of bone, there's an excessive amount of bone resorption and haphazard bone growth. There's a lytic phase, a mixed phase, and a sclerotic phase, which result in weak and hypervascularized bones. Paget disease of bone is usually asymptomatic, but can result in misshapen bones that cause fragility fractures and lead to nerve compression. Rickets and osteomalacia are conditions in which bone softening occurs due to a mineral deficiency or lack of vitamin D. Now, rickets presents in children and osteomalacia in adults, and symptoms depend on if there was growth plate closure. Nonetheless, some key symptoms of rickets are craniotabes and bow legs. In both osteomalacia and rickets, there can be diffuse bone and joint pain, proximal muscle weakness, bone fragility, and increased risk of fractures with minimal trauma. Now back to our cases. Jenna is the 70-year-old woman who presents with hip pain after falling while getting out of bed. She sustained a fragility fracture of the right hip, and preoperative chest x-ray also reveals that she had existing asymptomatic vertebral fractures before her fall. Based solely on the fact that Jenna is an older female who suffered a fragility fracture of the hip, we should suspect osteoporosis, although we need to rule out other metabolic diseases. DEXA confirms our diagnosis by showing a T-score of negative 2.8 standard deviations. Gerald, on the other hand, is the 46-year-old man who presents with a mild but noticeable limp and right hip pain after falling from a chair. Examination was unremarkable, but radiographs of the hip showed generalized sclerosis and increased radiodensity of the hip bones. Now, based on his clinical picture, we should suspect osteopetrosis tarda, although genetic testing would be required to confirm the diagnosis.
The word osteomyelitis can be broken down. Osteo refers to bones. Myel stands for myelo and relates to the bone marrow. And lastly, itis refers to inflammation. So osteomyelitis is an inflammation of the bone or bone marrow, and it typically results from an infection. Normally, if we look at a cross-section of a bone, we can see that it has a hard external layer known as the cortical bone and a softer internal layer of spongy bone that looks like honeycombs. There's also another layer called the periosteum that covers the cortical bone, like the lamination of a basketball card, and that's where the muscles, tendons, and ligaments are attached. If we zoom into a cross-section of cortical bone, we can see that it has many pipe-like structures called osteons running through the length of the bone. Each pipe has an empty center, called a haversian canal, which contains the nerves and blood vessels that supply the osteon. At the outer border of the osteon is a ring of cells called osteoblasts, which synthesize bone. Along with these cells are osteoclasts that break down bone. In bones like the long femur, the tips are called the epiphysis, while the shaft is called the diaphysis. Between them, we have the metaphysis, which contains the growth plate, the part of the bone that grows during childhood. In osteomyelitis, microorganisms such as bacteria reach the bone to cause an infection in a few different ways. Bacteria particularly affect certain high-risk individuals, like those with a weak immune system and those with poor blood circulation due to uncontrolled diabetes. In fact, a major way that bacteria reach the bone is through the bloodstream, and that's called hematogenous spread. For example, this might happen in a person who uses contaminated needles to inject drugs, or in individuals undergoing hemodialysis that may be contaminated by a bacteria, or even through the dental extraction of an infected tooth. Through the bloodstream, the microorganisms may reach specific places in the body, and this mostly depends on the age of the person. In older adults, for example, the microorganisms may reach the vertebrae and cause vertebral osteomyelitis. This usually affects two adjacent vertebrae and the intervertebral disc between them. In children, the metaphysis of long bones like the femur is commonly affected. The second way that bacteria cause osteomyelitis is through trauma. For example, in an open fracture after an accident, the bone may get exposed to the outside environment and come into direct contact with bacteria. A third way is during surgery, when there's bacteria that's introduced into the bone. A fourth way is when an infection spreads from one area, like cellulitis, which is an infection of the dermis layer of the skin, to an adjacent area, like the bone.
Ow!
And this is known as contiguous spread. There can also be combinations of these. For example, when a prosthetic joint becomes contaminated with bacteria during surgery, and then that bacteria contiguously spread to nearby bone. Another example is when people with diabetes mellitus develop a severe vascular compromise. A small trauma to the foot can lead to the formation of a foot ulcer, which then becomes infected and spreads to the nearby bone. Now, once the bacteria reach the bone by any of these routes, they start to proliferate. This alerts nearby immune cells, specifically dendritic cells and macrophages, that try to fight off the infection. This represents the acute phase of the disease and occurs over a course of weeks. The immune cells release chemicals and enzymes that break down bone and cause local destruction. Usually, acute osteomyelitis comes to a resolution, meaning that the immune system eventually destroys all of the invading bacteria. If the lesion is not that extensive and there's viable bone, the osteoblasts and the osteoclasts begin to repair the damage over a period of weeks. However, in some cases, the process turns into chronic osteomyelitis, lasting months to years. In that situation, the affected bone sometimes becomes necrotic and separates from the healthy part of the bone, and that's called a sequestrum. At the same time, the osteoblasts that originate from the periosteum may form new bone that wraps the sequestrum in place. This is called an involucrum. Occasionally, in both acute and chronic osteomyelitis, the inflammation may involve the periosteum. The periosteum is loosely attached to the compact bone, especially in children, so the two layers can separate and allow an abscess to form between them. That sort of an abscess tracks along the periosteum, lifting it up away from the compact bone. The infection can also spread further to involve a nearby joint, particularly the knee or hip joint in young children, as well as overlaying muscle, skin, and even get into the blood vessels, causing thrombophlebitis. Many microorganisms cause osteomyelitis, but the most common is Staphylococcus aureus, a grape looking bacteria that lives on the skin. It can invade the skin and spread contiguously to the bone, or it can reach the bone through the bloodstream. Another one is Salmonella, a rod shaped bacteria that particularly affects individuals with sickle cell disease. Unfortunately, individuals with sickle cell disease are therefore at risk of getting both Staphylococcus aureus as well as Salmonella infections. Another pathogen is Pasteurella multisida, a pill-shaped bacteria. It usually spreads from the skin to the bone from a bite or scratch from a cat or dog. Now, acute osteomyelitis typically causes pain at the site of infection, as well as fevers. Depending on the location, it may affect use of the bone. In chronic osteomyelitis, there can be prolonged fevers and weight loss due to the chronic inflammatory state. Osteomyelitis is usually diagnosed by using a complete blood count, or CBC, which shows an increase in white blood cells, as well as an elevated erythrocyte sedimentation rate, or ESR, and C-reactive protein, or CRP. These are both nonspecific markers of inflammation. Now, in addition, sometimes an X-ray is done, and it might show thickening of the cortical bone and periosteum, as well as an elevation of the periosteum. Other findings may include loss of the normal architecture of the bone, especially of the trabecular architecture. There's also osteopenia, or loss of bone mass that becomes evident when more than half of the bone matrix is destroyed. Typically, a bone scan, or MRI, is done to help confirm the presence of osteomyelitis and to identify a possible abscess. When possible, a bone biopsy is also taken to help culture and identify the pathogen responsible, as well as confirm the diagnosis. Now, treatment typically involves weeks of antibiotics directed at the organism causing the infection. If there's an abscess, particularly a vertebral abscess, causing neural compression or spinal instability, then surgery may also be required. In addition to draining abscesses, surgery is often needed to remove any necrotic bone, particularly in chronic osteomyelitis where the sequestrum has to be removed. Alright, as a quick recap. Osteomyelitis is a bone infection, in which the symptoms are inflammation, fever, and weakness. Staphylococcus aureus is the most common pathogen responsible for osteomyelitis, and the most common form of infection is through the bloodstream.
While doing your rounds, you see two individuals. The first is James, a 14-year-old boy who came in for chronic right knee pain, night sweats, and weight loss. He didn't report falling or any other trauma to the region or any additional symptoms. On examination, his right knee is slightly larger than the left, and on palpation, a hard mass can be felt on the metaphysis of his right femur, close to the knee region. Then you see William, who's 22 years old and complains of a 1-month history of bone pain along his left tibia, a problem which is worse at night. One interesting observation he made was that the pain responds well to ibuprofen, a non-steroidal anti-inflammatory drug. On examination, palpation reveals a bony mass on the anterior surface of the left tibial diaphysis. As expected, X-ray scans were obtained. They showed a distal sunburst appearance and Codeman's triangle in James' right femur, whereas Williams' X-ray scans detected a small lesion under 2 centimeters with a radiolucent core on the anterior surface of his left tibia. Now, both seem to have some type of bone tumor, but first a bit of physiology. Even though the bones vary in size and shape, all bones are made of the same type of cells, and chief among them are osteoblasts, which build up new bone, and osteoclasts, which help with bone breakdown or resorption. Now, in addition to these, there are some more primitive cells in the bone marrow called human mesenchymal stem cells and neuroectodermal cells, which can differentiate into many cell types, including nerve, fat, bone, and cartilage cells. In terms of anatomy, looking at a long bone like the femur, it has two epiphyses, which are the ends that contribute to joints with other bones. Between the two epiphyses is the diaphysis, also called the bone shaft. In children and adolescents, there's an additional narrow portion between the epiphysis and the diaphysis called the metaphysis. The metaphysis contains the growth plate, the part of the bone that grows during childhood. In adults, the growth plate is ossified and fused with the diaphysis and the epiphysis. Bone tumors form when bone cells divide uncontrollably and forms a mass or tumor. If the tumor remains confined and does not spread into surrounding tissues, then it's considered benign. But if the tumor invades into surrounding tissues and metastasizes or spreads through blood or lymph, then it's considered malignant. Malignant tumors can either be primary, which is when they arise from the bone cells, or secondary, which is when a tumor develops somewhere else in the body, like the breast, prostate, lungs, thyroid, or kidneys, metastasized and spread to the bones. So let's start with benign bone tumors. The most common one is osteochondroma, and it commonly affects males under the age of 25. Osteochondroma is thought to arise from the growth plate tissue, and it's caused by mutations in the exostosin 1 or EXT1 and exostosin 2 or EXT2 genes. These genes encode proteins with the same names that help synthesize heparin sulfate, which regulates growth plate growth. So as a result, osteochondroma typically develops as a lateral bony projection, which contains a marrow cavity that's continuous with that of the underlying bone. This bony stalk is called an exostosis, and it has a cap, made mostly of hyaline cartilage. Now, given their growth plate origin, a high-yield fact is that osteochondromas typically develop in the metaphysis of long bones, usually the distal femur and the proximal tibia. This type of tumor can sometimes undergo malignant transformation into chondrosarcoma, but this is uncommon. Another benign tumor is the giant cell tumor of the bone, more common in those 20 to 40 years old. The tumor consists of reactive osteoclast-like cells, which have numerous nuclei, typically over 50, and of neoplastic mononuclear cells that express rank L, a receptor that mediates osteoclast formation, differentiation, and survival. A well-known risk factor is having bone trauma like a fracture or radiation exposure. Now, this tumor typically arises in the knee region, in the epiphysis of the long bones, like the distal femur and the proximal tibia. And although it rarely becomes malignant, it's still considered a locally aggressive benign tumor. Next, we have osteoblastoma, which is more common in males, and osteoid osteomas, which is also more common in males, but it's more frequent in those under 25 years of age. A high-yield concept is that both of these tumors arise from osteoblasts, and they form a nidus, which is a disorganized mix of small blood vessels, tiny rods of bone called trabeculi, and unmineralized bone tissue called osteoid. In osteoblastomas, the nidi are larger, with a diameter of over 2 centimeters. In osteoid osteomas, the nidi are smaller than 2 centimeters in diameter and are often surrounded by a ring of sclerotic bone tissue. That ring of sclerotic tissue often produces prostaglandins, which are small molecules that trigger the sensation of pain. This explains why nonsteroidal anti-inflammatory drugs, or NSAIDs, that decrease prostaglandin production work so well in relieving the pain associated with this tumor. In contrast, in osteoblastoma, pain is unresponsive to NSAIDs. Osteoblastomas also tend to affect the vertebrae, where they cause bone erosion, whereas osteoid osteomas typically affect the cortex of long bones like the tibia, and do not usually erode the surrounding bone. Osteomas are benign tumors that typically affect middle-aged people. They consist primarily of well-differentiated, mature, compact, or trabecular bone, and are typically found on the surface of facial bones. Something else interesting about them is that they're associated with Gardner syndrome, which is an autosomal dominant form of polyposis characterized by multiple polyps in the colon, together with tumors outside the colon. Malignant transformation has not been reported in these tumors. And finally, chondromas are benign tumors of cartilage, with a lobular growth pattern. They arise from cells called chondrocytes, which produce and maintain the cartilaginous matrix, and are typically located within the medullary cavity of the small bones of the hands and feet. Now, switching to malignant tumors, remember that malignant metastases to the bones are much more common than primary bone tumors, and they have a predilection for the axial skeleton. For primary malignant bone tumors, osteosarcoma is the most common, accounting for around 20% of all bone cancer cases, especially in males under 20 years of age. It's not as prevalent in older individuals, where it usually develops secondary to predisposing factors, like Paget disease of the bone, which is a condition where there's abnormal bone remodeling, bone infarcts, familial retinoblastoma, which is a childhood malignant tumor of the eye, and Lee-Fraumeni syndrome, a condition in which there's a variety of cancers throughout the body. Osteosarcomas arise from osteoblasts, and the neoplastic cells are often different sizes, called pleomorphic, and they produce too much osteoid tissue. Some high-yield mutations associated with these pleomorphic osteoblasts include mutations in the PRB protein, also seen in familial retinoblastoma, and the P53 protein, which is also seen in Lee-Fraumeni syndrome. Location-wise, the tumors often form in the metaphysis of long bones, especially in the knee region, because the cells there divide constantly. Osteosarcoma is very aggressive, with primary tumors having a better prognosis because they usually respond to treatment, whereas secondary osteosarcomas have much more reserved prognosis because they don't typically respond well to chemotherapy or surgery. Another type of malignant bone tumor is Ewing's sarcoma, which is common in male Caucasian adolescents under 15 years of age. Origin-wise, there's still some debate, but most seem to think the tumor arises from either neural crest cells or mesenchymal cells. Regardless of their origins, these malignant cells look like small, round, blue cells that resemble lymphocytes on microscopy, which is why Ewing's sarcoma needs to be differentiated from conditions with similar cells, like lymphoma and chronic osteomyelitis. Ewing's sarcoma is associated with chromosomal mutations, specifically a translocation between the FLI1 gene on chromosome 11 and EWSR1 gene on chromosome 22. The EWSR1 FLI1 fusion results in the expression of an abnormal protein called the EWSR1 FLI1 fusion protein, or simply the Ewing sarcoma protein. This protein causes defects in the differentiation process of human mesenchymal stem cells and neuroectodermal cells, resulting in Ewing sarcoma tumor cells. Alright, so the preferred location of this type of tumor is the diaphysis of long bones and the pelvic flat bones, especially the femur and the sacrum. Like most malignant tumors, Ewing sarcoma is aggressive, resulting in early metastases. But the good news is that it responds well to chemotherapy. There's also chondrosarcoma, which tends to affect the elderly. Chondrosarcoma arises from mutated chondrocytes, and mainly affects the medullary cavity of the bones of the pelvis, but can also affect long bones, like the humerus and proximal femur. Regarding symptoms, bone tumors, especially osteosarcomas, commonly cause local symptoms like bone pain, swelling due to inflammation or the tumor growing in size, decreased range of motion, and pathologic fractures. Some unique symptoms are the pain in osteoid osteoma, which typically gets worse at night and improves with NSAIDs, while osteochondromas and osteoblastomas sometimes press against spinal nerves, causing numbness and limb weakness. Additionally, they can cause avascular necrosis of the bone if the tumor starts pressing on a major blood vessel, which can worsen symptoms. Malignant tumors tend to cause a chronic inflammatory response, which leads to fever, night sweats, and weight loss. Bony tumors often metastasize to the lungs, so in that setting, there can be pulmonary symptoms like coughing and shortness of breath as well. The diagnosis of bone tumors starts with medical imaging, with some tumors having a few classic X-ray findings that's very high yield. For example, osteochondroma causes exostoses. Giant cell tumor forms multicystic bone lesions that look like soap bubbles. An osteoid osteoma is typically seen as a bony mass under 2 centimeters with a radiolucent core. Osteosarcoma forms lytic bone lesions, referred to as a sunburst appearance, because the radiating tumor streaks look like sun rays, or it can cause the periosteum to lift, an appearance which is called Codman's triangle. In Ewing sarcoma, X-ray shows lytic bone lesions referred to as onion skin appearance, because the periosteum looks like a sliced onion bulb. In chondrosarcoma, there are patchy lytic lesions that make the bone look like a moth-eaten piece of cloth. When radiographic findings raise suspicion for bone malignancy, laboratory studies like urinalysis, erythrocyte sedimentation rate, liver function testing, blood urea nitrogen, and creatinine levels should be obtained to evaluate other symptoms and to look for signs of metastasis. Treatment depends on whether the tumor is malignant or benign. Symptomatic benign tumors can be surgically removed to reduce pain and the risk of fractures, while malignant tumors are treated with radiotherapy, chemotherapy, and surgery, depending on the type and spread of the tumor. Now, a final disorder that can cause bone tumors is multiple myeloma, which is the most common primary bone tumor in people 40 to 50 years of age. Multiple myeloma is a cancer of plasma cells in the bone marrow. Plasma cells start their journey as B lymphocytes in the bone marrow, which move to the lymph nodes where they mature into antibody-secreting plasma cells. When this happens, adhesion molecules stimulate myeloma cells to migrate to the bone marrow and adhere to bone marrow stromal cells in the extracellular matrix. This in turn stimulates bone marrow stromal cells to release cytokines, which promote osteoclast activity and impair osteoblast formation, resulting in bone destruction and hypercalcemia. Another way myeloma cells cause damage is by secreting excess IgG or IgA, which have both a heavy and light chain. More rarely, the myeloma cells can only make the kappa or lambda light chains, and in that situation, the resulting protein is called a Bence-Jones protein, which can be a key clue on your exams. Now, a high-yield concept is the clinical presentation of multiple myeloma, which can be summarized with the mnemonic CRAB. C is for hypercalcemia, which results from increased osteoclast activity. Your exams might not just give you the lab finding, but instead give you some symptoms of hypercalcemia, like abdominal pain, psychiatric changes, constipation, or fatigue. Alright, R is for renal disease, which can be caused by multiple mechanisms. First, the light chains can deposit in and obstruct the renal tubules, and this is called light chain cast nephropathy, or myeloma kidney. A second cause is type 2 renal tubular acidosis, or even hypercalcemia, which might result in the formation of calcium phosphate kidney stones. Third is by primary amyloidosis. In this type of amyloidosis, the immunoglobulin light chains leave the circulation and abnormally aggregate in various tissues, resulting in various clinical manifestations. These include restrictive cardiomyopathy, a large tongue, also called macroglossia, and nephrotic syndrome, to name a few. A is for anemia, which causes fatigue and shortness of breath. Anemia occurs because the malignant cells infiltrate the bone marrow and proliferate, crowding out the normal cells that form components of the blood. Finally, B is for bone pain, which is due to increased osteoclast activity causing pathologic fractures and lytic bone lesions. So in your exams, look for an elderly individual with symptoms of anemia and chronic back pain. Other manifestations include spinal cord compression if the tumor infiltrates from the vertebrae, and frequent infections, because the immunoglobulins secreted by myeloma cells are not functional immunoglobulins, and so they're not useful in fighting infections. Also remember that a workup for multiple myeloma includes a complete blood count, which often shows normocytic normochromic anemia, and a peripheral smear, which can show a rouleau formation due to IgG proteins attaching to red blood cell membranes, and then connecting with other red blood cell membranes, making the red blood cells stick to one another, and causing them to look like a stack of coins. Additionally, serum calcium levels, blood urea nitrogen, uric acid, and creatinine concentrations might be elevated. Serum and urine protein electrophoresis, or SPEP and UPEP, respectively, are important to see which M protein is predominantly being produced, and is seen as an M spike. SPEP detects most multiple myeloma patients that predominantly make IgG, followed by IgA, while UPEP is used to detect the minority of multiple myeloma individuals, who only make the Bence-Jones protein. UPEP is needed because these light chains are rapidly filtered from the blood, so they may not be seen on SPEP. Next, beta-2 microglobulin, a component of the major histocompatibility class I antigens found on all nucleated cells, can be shed in the serum. This is why serum levels are checked in multiple myeloma, because the higher beta-2 microglobulins are, the higher the severity of the disease. Then a skeletal radiographic survey should be done to look for punched-out lytic lesions, which are a classic finding you should remember. Finally, another high-yield fact is that a bone marrow aspiration and biopsy must be obtained to look for more than 10% plasma cells which infiltrate into the bone marrow. These plasma cells tend to give off a fried egg appearance. Alright, as a quick recap. Benign tumors include osteochondroma, which presents with exostoses, giant cell tumor, which has giant cells and looks like soap bubbles on X-ray, osteoid osteoma, characterized by a nidus less than 2 cm with a radiolucent core, osteoblastoma, whose nidus is greater than 2 cm, osteomas, which consist primarily of well-differentiated mature, compact, or trabecular bone, and chondromas, which are benign tumors of cartilage, with a lobular growth pattern. The primary malignant tumors include osteosarcoma, which is made of large pleomorphic cells and has a sunburst appearance on X-ray, Ewing sarcoma that has round blue cells and a sliced onion appearance on X-ray, and chondrosarcoma, which has large multinucleated chondrocytes and a moth-eaten appearance on X-ray. Among the more important mutations, osteosarcoma is linked to RB1 and TP53 gene mutations, while Ewing sarcoma is thought to arise when there's an EWSR1 and FLI1 gene mutation. There's also multiple myeloma, which is a cancer of plasma cells that cause bone destruction secondary to cytokine release. Clinical presentation can be summarized with the mnemonic CRAB. C is for hypercalcemia, R for renal disease, A for anemia, and B for bone pain. A skeletal radiographic survey can show punched-out lytic lesions, and bone marrow biopsy can show more than 10% plasma cells with a fried egg appearance. Now back to our cases. James is 14 years old and presents with rather nonspecific complaints like right knee pain, night sweats, and weight loss, without any history of local trauma. Examination shows a swollen right knee and a hard mass in the distal part of the right femoral metaphysis, which was accompanied by a sunburst appearance and Codeman's triangle on X-ray. Now, given his age, symptoms, and typical X-ray findings, we can assume that James has osteosarcoma. William, who is 22 years old, also presents with a chronic history of pain, this time along his left tibia, a problem which is worse at night but responsive to NSAIDs. Examination revealed a bony mass on the anterior surface of the left tibial metaphysis, which was confirmed by an X-ray scan showing a small lesion under 2 cm with a radiolucent core. Given the specific features of his age, his pain, and tumor location, we can assume William's diagnosis is osteoid osteoma.
Bone tumors form when a bone cell divides uncontrollably and forms a mass or tumor. If the tumor remains confined and doesn't spread into surrounding tissues, then it's considered benign. But if the tumor invades into surrounding tissues and metastasizes or spreads through blood or lymph, then it's considered malignant. Malignant tumors can either be primary, which is when they arise from bone cells, or secondary, which is when a tumor develops somewhere else in the body, metastasized, and spread to the bones. The most common sources of tumor cells that affect the bones but start somewhere else in the body are the breast, prostate, the lungs, the thyroid, and the kidneys. Now, even though bones vary in size and shape, they're all made of the same types of cells. And chief among them are osteoblasts, which build up new bone, and osteoclasts, which help with bone breakdown or resorption. Now, in addition to these, there are some more primitive cells in the bone marrow, called human mesenchymal stem cells, and neuroectodermal cells, which have the ability to differentiate into many cell types, including nerve, fat, bone, and cartilage cells. Now, in terms of anatomy, looking at a long bone, like the femur, it has 2 epiphyses, which are the ends that contribute to joints with other bones. Between the 2 epiphyses is the diaphysis, also called the bone shaft. In children and adolescents, there is an additional narrow portion between the epiphyses and the diaphysis called the metaphysis. The metaphysis contains the growth plate, the part of the bone that grows during childhood. In adults, the growth plate has ossified and fused with the diaphysis and the epiphysis. Now, there are genes that promote normal cell growth called proto-oncogenes. With mutations, proto-oncogenes become oncogenes, and these overstimulate the cell growth. To balance out cell growth, there are other genes called tumor suppressor genes, which promote apoptosis or cell death of mutated cells. So oncogenes, or mutated tumor suppressor genes, allow cells to keep growing uncontrollably, resulting in tumors. Alright, primary bone tumors can be divided up into ones that are most often benign and those that are most often malignant. Let's start with the most common benign tumor, which is an osteochondroma, and commonly affects males under 25 years of age. Osteochondroma is thought to arise from mutations in the exostosin 1, or EXT1, and exostosin 2, or EXT2 genes, which encode the exostosin 1 and 2 proteins. These proteins help to synthesize heparin sulfate, which is a protein that regulates the growth of the growth plate. So in osteochondroma, a tumor arises from the growth plate, and it typically results in a lateral bony projection. This bony stalk is called an exostosis, and it has a cap made mostly of hyaline cartilage. Now, osteochondromas typically develop in the metaphysis of long bones, most commonly the distal femur and the proximal tibia around the knee joint, but they can also occur in flat bones like the ilium, one of the hip bones, as well as the scapula. Another benign tumor is the giant cell tumor of the bone, quite a name. A risk factor for giant cell tumors is having a bony trauma like a fracture or radiation exposure. The tumor cells arise from osteoclast cells, but then develop into cells that have numerous nuclei, typically over 50 nuclei, so you can think of them as destructive little giants. The giant cell tumor typically arises in the epiphysis of the long bones, like the distal femur and proximal tibia. On rare occasions, this tumor can become malignant, especially in elderly individuals. Other benign tumors are osteoblastomas and osteoid osteomas, both of which arise from osteoblasts. Both of these tumors classically form a nidus, which is a disorganized mix of small blood vessels, tiny rods of bone called trabeculae, and unmineralized bony tissue called osteoid. In osteoid blastomas, the nidi, which is plural for nidus, are large with a diameter of over 1.5 centimeters. In osteoid osteomas, the nidi are smaller than 1.5 centimeters in diameter and are often surrounded by a ring of sclerotic bone tissue. That ring of sclerotic tissue often produces prostaglandins, which are small molecules that trigger the sensation of pain. Osteoblastomas also tend to affect the bones of the axial skeleton, usually the mandible, and erode the surrounding bone. In comparison, osteoid osteomas typically affect the diaphysis of long bones like the tibia and don't usually erode the surrounding bone. Now, among malignant tumors, the most common one is osteosarcoma. Osteosarcomas arise from osteoblasts of different sizes, called pleomorphic, and these cells produce too much osteoid tissue. Osteosarcomas often form in the metaphysis where there's a lot of cell division occurring. They most commonly affect adolescents. Some known mutations that are linked to osteosarcomas include mutations of the PRB protein, also seen in familial retinoblastoma, a childhood malignant tumor of the eye, and the P53 protein, which is also seen in Li-Fraumeni syndrome, a condition where there are a variety of cancers throughout the body. Another type of malignant bone tumor is Ewing sarcoma, which is also common in adolescents, typically between the age of 10 to 20 years. Ewing sarcoma is thought to arise from neuroectodermal cells, which look like small, round blue cells on microscopy. Ewing sarcoma is associated with chromosomal mutations, specifically a translocation between the EWSR1 gene on chromosome 22 and the FLI1 gene on chromosome 11. You can remember this by 22 plus 11 equals 33, the jersey number of the former basketball player Patrick Ewing. The EWSR1 FLI1 fusion results in the expression of an abnormal protein called, you guessed it, the EWSR1 FLI1 fusion protein, or more simply, the Ewing sarcoma protein. This protein causes defects in the differentiation process of human mesenchymal stem cell and neuroectodermal cells, resulting in Ewing sarcoma tumor cells. Ewing sarcoma can affect a number of different bones, but most commonly affects the femur and the sacrum. Finally, there are chondrosarcomas, which tend to affect the elderly. Chondrosarcoma arises from the chondrocytes, which are cartilage-producing cells. Chondrosarcoma mainly affects bones of the pelvis, but can also affect long bones like the proximal femur and proximal humerus. On imaging, the mass is typically within the medullary cavity. Bone tumors commonly cause bone pain, swelling, and fractures. Some unique symptoms are that the pain of osteoid osteoma typically gets worse at night, while osteochondromas and osteoblastomas sometimes press against spinal nerves, causing numbness and limb weakness. They can also cause avascular necrosis of certain regions within the bone if the tumor impinges on a major blood vessel. Malignant tumors typically cause a chronic inflammatory response, which leads to fever, night sweats, and weight loss. Bony tumors often metastasize to the lungs, so in that setting they can cause pulmonary symptoms like coughing and shortness of breath. The diagnosis of bone tumors starts with medical imaging, like X-rays, CT scans, and MRI imaging, or testing for serum tumor markers that are specific for each type of tumor. Some tumors also have some classic X-ray findings. For example, osteochondroma causes exostoses, while the giant cell tumor forms multicystic bone lesions that look like soap bubbles. Osteosarcoma form lytic bone lesions, referred to as a sunburst appearance, because the radiating tumor streaks look like sun rays. Osteosarcomas also cause the periosteum to lift, and that's commonly called Codman's triangle. In Ewing sarcoma, X-ray shows lytic bone lesions referred to as an onion skin appearance, because the periosteum looks like a sliced onion bulb. In chondrosarcoma, there are patchy lytic lesions that make the bone look like a moth-eaten piece of cloth. The treatment of bone tumors depends on whether they are malignant or benign. Benign tumors can be surgically removed to reduce pain and the risk of fractures, while malignant tumors are treated with radiotherapy, chemotherapy, and surgery, depending on the type and the spread of the tumor. Alright, as a quick recap. Benign tumors include osteochondroma, which presents with exostosis, giant cell tumor, which has giant cells and looks like soap bubbles on X-ray, osteoid osteoma, characterized by a nidus less than 1.5 centimeters, and osteoblastoma, whose nidus is greater than 1.5 centimeters. The primary malignant tumors include osteosarcoma that are made of large pleomorphic cells and have a sunburst appearance on X-ray, Ewing sarcoma that has round blue cells and a sliced onion appearance on X-ray, and chondrosarcoma, which has large multinucleated chondrocytes and a moth-eaten appearance on X-ray. There are no known causes of the bone tumors, but among risk factors we have rapid bone growth, bone trauma, exposure to radiations, and positive family history of bone tumors. Osteosarcoma is linked to RB1 and TP53 gene mutations, while Ewing sarcoma is thought to arise when there are EWSR1 and FLI1 gene mutations. Benign tumors can be surgically removed if they're causing symptoms, while the treatment for malignant tumors requires radiotherapy, chemotherapy, and surgery.
In HBO's adaptation of Game of Thrones, the character Tyrion Lannister is treated poorly by his father and siblings because he's born with dwarfism. In a classic scene in the show, he says,
I'm guilty of being a dwarf.
You're not on trial for being a dwarf.
Oh, yes I am. I've been on trial for that my entire life.
Both Tyrion and his real-life counterpart, Peter Dinklage, have achondroplasia, an autosomal dominant genetic condition which is the most common cause of dwarfism and results from a heterozygous mutation in a gene called FGFR3, or fibroblast growth factor receptor 3, on chromosome 4, which codes for the FGFR3 protein. When FGFR3 protein binds fibroblast growth factors, or FGFs, it slows down the growth of certain bones. The mutation causing achondroplasia is almost always the 380th amino acid, which is glycine, getting swapped out for arginine in the FGFR3 protein. And this swap causes the FGFR3 receptor to be constitutively active, which means constantly active. In other words, the mutation makes the receptor behave as though it's binding an FGF even when it's not, which sends a strong signal to inhibit bone growth. More specifically, FGFR3 that's always on causes chondrocytes at the growth plate to proliferate slowly and become disorganized. So because of this, it mostly affects endochondral bone formation, which is the process of bone forming right on previously laid down cartilage matrix, which causes the bone to elongate. With the mutation though, this elongation is inhibited, which means long bones like the humerus and phalanges are affected. Alright, so the mutation affects endochondral bone formation, but bones that are products of intramembranous bone formation are way less affected. And this is where bone grows without an existing cartilage matrix. This includes flat bones like the skull and the ribs. Also, an intramembranous process is appositional growth, which is the process of widening the long bones. So that happens pretty normally too. The result of shortened long bones is dwarfism with disproportionate short stature, where the limbs are short while the trunk and head size is largely preserved. Specific long bone defects include rhizomelic, or proximal, shortening of the limbs, varus leg deformity, or knees out, short metacarpals creating a broad hand, and short phalanges causing brachydactyly, literally meaning short fingers. When outstretched, the fingers form a shape called a trident hand, where the tips of the fingers can't touch each other. Flat bone defects, on the other hand, although less pronounced, do exist, and can include large head size, frontal bossing, flattened nasal bridge, a narrow foramen magnum, and spinal lordosis. Although there are a lot of changes to the skeleton, a person's other organs, intelligence, lifespan, and fertility are all normal. Long bone shortening is often pronounced enough that achondroplasia can be diagnosed by prenatal ultrasound. The ratio of skull width, or biparietal diameter, to femur length in this case is higher than normal. Also, a DNA test can confirm the diagnosis either before or after birth. A skeletal survey, which is just a series of x-rays that capture much or all of the skeleton, can also confirm the diagnosis. Alternatively, though, it can suggest that a person might have another skeletal dysplasia, which is a blanket term for disorders of skeletal development, of which there are hundreds of types in addition to achondroplasia. Achondroplasia, though, is actually the most common skeletal dysplasia, and this is because of an incredibly high new mutation rate. New or de novo mutations come from the father, and get more frequent with increased paternal age, since sperm progenitor cells have more and more time to acquire mutations. Now, with achondroplasia, remember that it's a heterozygous mutation, meaning they have one copy of the FGFR3 gene with the mutation, but the other copy is normal. What if both mom and dad have achondroplasia, and they happen to both contribute an FGFR3 mutation to the child? Well, this results in homozygous achondroplasia, an extremely severe form of the disease that's lethal before or shortly after birth. On the other hand, though, what if neither parent transmits their FGFR3 mutation? Well, if that happens, then the child won't have achondroplasia. Alright, so what about treatment? Well, unfortunately for people with achondroplasia, there isn't a generally accepted way to increase height at the present time. Alright, so as a quick recap, achondroplasia is an autosomal dominant genetic disorder involving an FGFR3 mutation. FGFR3 is a receptor that inhibits bone growth, and the mutation causes it to be always on. So people with this develop dwarfism, with disproportionate short limbs and other skeletal abnormalities. Thanks for watching. You can help support us by donating on Patreon, subscribing to our channel, or telling your friends about us on social media. In the awesome Netflix series Stranger Things, the character Dustin's missing a few teeth, and he says,
I told you 1,000,000 times, my teeth are coming in. It's called cleidocranial dysplasia.
He's then asked to
Do the arm thing.
Both Dustin and his real-life counterpart, Gaten Matarazzo, have a rare genetic condition, cleidocranial dysplasia, or sometimes cleidocranial dysostosis. Cleido means clavicle, which is the collarbone, and cranial refers to the skull. Dys means abnormal, and plasia means formation. So people with cleidocranial dysplasia usually have underdeveloped or missing collarbones, which gives them a wide range of shoulder movement, as well as abnormalities in other bones, especially the skull bones, including the jaw, which can result in delayed eruption of the teeth. Now, cleidocranial dysplasia, or CCD, is a rare congenital disorder, meaning present since birth, and it's caused by a mutation in a gene on chromosome 6 located at 6p21, which means chromosome 6, the short arm, or P, region 2, and band 1. The gene's called CBFA1 or RUNX2, so let's just go with RUNX2. RUNX2 mutations are inherited in an autosomal dominant pattern, meaning if one parent has the disorder and one doesn't, 50% of their offspring will inherit the disorder and 50% won't. Those that inherit the disorder end up with one chromosome that has the mutation and one normal chromosome in every cell. And having just one chromosome with the mutation is enough to cause the disorder. Sometimes, though, the mutation might be sporadic, meaning it wasn't inherited from the parents, but it's a new mutation that just pops up in one of the children. This RUNX2 gene encodes for a specific RUNX2 protein that acts as a transcription factor. Transcription factors help control the activity of other genes, and it's thought that RUNX2 helps regulate genes involved in the differentiation of stem cells into osteoblasts, or bone-forming cells, as well as potentially chondrocytes, cells that help form cartilage. With CCD, if even one chromosome in each cell has a mutation in the RUNX2 gene, fewer functional RUNX2 proteins will be produced overall, meaning fewer functional osteoblasts and chondrocytes will be produced, and so they'll end up being delayed ossification, or delayed formation of bone. In about a third of cases of CCD, there doesn't seem to be any mutation in the RUNX2 gene, meaning that there's probably some other mechanism that's involved. In any case, as a result of these bone-forming cell abnormalities, people with cleidocranial dysplasia often have either underdeveloped or missing clavicles, or collarbones, which can give them increased range of shoulder movement. CCD is also commonly characterized by delayed or failed closure of the fontanelles, or soft spots in the skull. Other features might include supernumerary teeth, which are extra teeth that might appear in addition to the regular 32 teeth in the adult mouth, failure to shed the primary or baby teeth, as well as failed eruption of the permanent teeth. Also, a shorter stature and a number of other bone abnormalities have been observed in some people with CCD. As far as treatment goes, since it's a genetic mutation, there's no cure for cleidocranial dysplasia, although someone with CCD might benefit from surgical correction depending on the bone abnormality. Alright, as a quick recap, cleidocranial dysplasia or dysostosis is an autosomal dominant disorder that usually involves the RUNX2 gene, which helps control the differentiation of osteoblasts, which results in abnormal formation of various bone structures like the clavicle, the fontanelles, and the teeth. Thanks for watching. You can help support us by donating on Patreon, subscribing to our channel, or telling your friends about us on social media.
Lordosis, kyphosis, and scoliosis refer to curvatures of the spine. Lordosis refers to the normal inward curvatures of the spine at the cervical and lumbar regions, while kyphosis refers to the normal outward curvature of the spine, specifically at the thoracic region. These terms get used interchangeably with hyperlordosis and hyperkyphosis, which means that the curves look abnormally pronounced. Finally, there's scoliosis, which always refers to the abnormal sideways curvatures of the spine. Now, the bony spine is made of vertebral bones, and there are intervertebral discs that sit between adjacent vertebrae. The spine is made of 33 vertebrae, which can be divided into 5 regions. The cervical region has 7 vertebrae, the thoracic region has 12, the lumbar region has 5, the sacral region has 5 as well, and the small tail-like coccygeal region is made up of 4 fused vertebrae. Normally, the cervical and the lumbar spines slightly curve inward. This results from the fact that the intervertebral discs in these 2 regions are thicker anteriorly than posteriorly, which causes this part of the spine to lean forward. On the other hand, the thoracic and the sacral spines are normally curved backward, which is normal kyphosis. Lordosis and kyphosis are typically associated with underlying conditions. For example, in osteoporosis, the bones become porous and weak and can develop compression fractures, causing the bones to collapse a little bit. This can cause a spinal deformity and can also impinge on nearby nerves. Misaligned vertebrae can also exert too much pressure on the intervertebral discs, causing them to degenerate. Other conditions, like spondylolisthesis, in which a vertebrae slips out of its normal position, or conditions like Ehlers-Danlos syndrome and Marfan syndrome, where bones and connective tissues overgrow, causing spinal instability. Obesity can also put excess unbalanced weight on the spine, causing it to deform. Other causes include inflammation of the intervertebral discs, which can happen from overuse due to a sports injury or lifting weights in an inappropriate way. Lordosis typically affects the lumbar region and can specifically result from the trunk flexors and the hip extensors becoming too weak to balance the action of trunk extensors and hip flexors. When that happens, the lumbar spine gets overextended, causing it to progressively curve inwards, causing lumbar lordosis. Lordosis results in an incurved back in the cervical or lumbar spine. Kyphosis mainly affects the thoracic spine. It usually occurs when the front of the thoracic vertebrae gets deformed or crushed, causing this part of the spine to excessively bend forward. Kyphosis typically results in a rounded back in the thoracic spine, which looks like a hump in the upper back. There are a few types of kyphosis. First, there's postural kyphosis, which arises from repeated poor posture, like slouching for a long time. Postural kyphosis is most common in young females. Second, there's Scheuermann's kyphosis, which is when the vertebrae get structurally deformed and become wedge-shaped for an unclear reason. This is often associated with scoliosis, and it's referred to as kyphoscoliosis. Lastly, there's congenital kyphosis, which develops when the vertebrae get deformed during fetal development, resulting in a baby that's born with kyphosis. In general, if the condition is severe, it can reduce the space in the thoracic cavity, which can compress the heart and prevent the lungs from fully expanding. Finally, there's scoliosis, which is when the spine becomes twisted or develops a sideways curve, resembling an S or a C shape, often resulting in uneven shoulders and hips. The majority of the time, the underlying cause is unclear, and it's thought that it may be due to a defect in the composition of the intervertebral discs. These discs have a reduced amount of glycosaminoglycans, which changes their ability to act as shock absorbers, and causes the spine to become misshapen. Scoliosis is often seen in individuals with neuromuscular disorders that cause progressive muscle weakness, like cerebral palsy or muscular dystrophy. In severe scoliosis, there can be a deformity in the chest cavity, compressing the heart and the lungs, similar to what's seen in severe kyphosis. In terms of symptoms, spine deformities can cause mild to severe pain, and the stiffened spine can make it difficult to move. In severe kyphosis and scoliosis, the small thoracic cavity can lead to shortness of breath and an inability to exercise. The diagnoses for lordosis, kyphosis, and scoliosis are done by physical examination of the back. To figure out the extent of the spinal deformity, the Cobb angle can be measured. That's the measurement between two lines drawn perpendicular to the upper border of the uppermost vertebra and the lower border of the lowest vertebra involved in the curvature. In addition, radiographs of the back can be taken as well. Treatment of lordosis, kyphosis, and scoliosis typically includes physical exercises to limit the disease progression and maintain the range of motion, as well as pain medication when it's needed. For children and young adolescents, fixing braces can sometimes help prevent further spinal deformity. In rare situations, surgery may be needed. Alright, as a quick recap. Lordosis and kyphosis are usually secondary to diseases or injuries which deform the vertebrae and ligaments, such as vertebral fractures, spondylolisthesis, Ehlers-Danlos syndrome, and Marfan syndrome. Scoliosis is linked with some neuromuscular disorders like cerebral palsy or muscular dystrophy. In severe cases, lordosis, kyphosis, and scoliosis can cause back pain. And kyphosis and scoliosis may deform the chest, resulting in shortness of breath and cardiac failure. Treatment usually involves physical exercises, braces, and pain medication, or surgery in severe cases.
Bone softening caused by a faulty process of bone mineralization manifests as either rickets in children or osteomalacia in adults. Inadequate bone mineralization could be due to a deficient or impaired metabolism of vitamin D, phosphate, or calcium. But first, a bit about bones. Now, long bones like the femur are made up of two epiphyses, which are its ends, and the diaphysis, which is the shaft. Between each epiphysis and the diaphysis, there is a region called the metaphysis, and the metaphysis contains the epiphyseal plate, or the growth plate, which is the part of the bone that grows during childhood. Once growth stops, the growth plate is replaced by an epiphyseal line, and this is known as epiphyseal closure. Now, for bones to grow and develop properly, special bone cells called osteoblasts are hard at work. To build bone, osteoblasts secrete osteoid, which is an organic matrix made up of type 1 collagen. These collagen fibers are the framework for the osteoblast's work. Osteoblasts then deposit calcium and phosphate crystals into the framework. This process is called bone mineralization, and it confers strength to the growing bones. Bone mineralization is dependent on an enzyme called alkaline phosphatase, which increases in response to osteoblast activity. So at the end of the day, bones are like a storage warehouse for calcium and phosphate. Now, the levels of calcium and phosphate in the bone, but also in the blood, are regulated by vitamin D and parathyroid hormone, or PTH. Vitamin D-wise, two steps are necessary for optimal metabolism. First, there must be enough vitamin D in the body, either from food or created in the skin in response to sunlight exposure. Secondly, vitamin D must become metabolically active, and this process also has two steps. First one happens in the liver, where inactive vitamin D is converted into 25-hydroxyvitamin D by the enzyme 25-hydroxylase. 25-hydroxyvitamin D then travels to the kidneys, where the enzyme 1-alpha-hydroxylase converts it to 125-hydroxyvitamin D, or calcitriol, which is the active form of vitamin D. Calcitriol increases renal tubular reabsorption of calcium, which reduces the loss of calcium in the urine. Calcitriol also increases the intestinal absorption of calcium and phosphate. Okay, now let's have a quick look at parathyroid hormone. Parathyroid hormone is secreted in response to low blood calcium levels, and it stimulates the resorption of calcium and a small amount of phosphate from the bone and into the bloodstream. Additionally, parathyroid hormone can boost 1-alpha-hydroxylase activity, which forms more active vitamin D, increasing gut absorption of calcium. Lastly, parathyroid hormone increases calcium reabsorption and reduces the reabsorption of phosphate from the kidneys, so more phosphate is excreted through the urine. Now, when there's not enough active vitamin D, calcium, or phosphate, there's inadequate mineralization. This means that osteoblasts don't have enough calcium and phosphate to deposit into the organic matrix. In children, because the growth plates haven't closed yet, This leads to softening of the bones, impaired growth of bones, and bone malformations. Whereas in adults, where the epiphyseal plates have already closed, it only causes weakening and softening of bones, which makes them easier to fracture. Okay, now vitamin D deficiency is the most common cause of both rickets and osteomalacia. Causes of vitamin D deficiency include intestinal malabsorption, which can be seen with celiac disease or Crohn's disease, not enough UV light exposure, like in homebound elderly populations. Medications like phenytoin, an anticonvulsant, uses liver and kidney hydroxylase enzymes for its own metabolism, so especially with long-term use, there's not enough vitamin D being generated. And finally, there's liver and kidney disease. For example, rickets or osteomalacia can occur in chronic liver disease due to the liver's inability to turn inactive vitamin D into 25-hydroxyvitamin D. The same goes for chronic kidney disease, where the kidneys can't turn 25-hydroxyvitamin D into 125-hydroxyvitamin D. Both conditions result in an active vitamin D deficiency, which leads to impaired bone mineralization. With both rickets and osteomalacia, symptoms include diffuse bone and joint pain, proximal muscle weakness, bone fragility, and increased risk of fractures with minimal trauma. Because of low levels of calcium, there may also be muscle spasms and numbness. Ricket-specific symptoms include thin, soft skull bones, which is called craniotabes, delay in the closure of fontanelles, and bow legs, also known as genu varum. There may also be an enlarged prominent frontal bone and with severe disease a protruding abdomen. Additionally, a ricketic rosary may be seen. This is when little bumps appear along the chest due to the widening of the junction between the ribs and the costal cartilage in front of the rib cage. Rickets and osteomalacia are usually diagnosed with lab tests, which show abnormally low vitamin D levels in blood serum, low blood calcium, and elevated serum alkaline phosphatase. As a result of low calcium, there may also be high PTH, which may also lead to low serum phosphate. Now, X-ray imaging of rickets and osteomalacia might show signs of decreased bone mineral density or osteopenia. First, there's looser zones, which are bands of low bone density that form on the surface of the bone. And they look a bit like bone fractures, so they're also called pseudofractures. Looser zones frequently develop in the inferior and superior pubic rami of the pelvic bone. In rickets, an X-ray image of the wrist and long bone metaphyses might demonstrate metaphyseal cupping and flaring. With metaphyseal cupping, the edges of the metaphysis widen laterally, like flared jeans, and the metaphysis itself drops inwards towards the diaphysis, which makes it look a bit like a cup. Another X-ray finding in rickets is metaphyseal fraying. Instead of the metaphyseal surface appearing smooth, it appears fuzzy and irregular. Finally, another X-ray finding with rickets may be bowing of the legs. Treatment for both rickets and osteomalacia typically involves oral vitamin D supplementation and treating the underlying cause, which could be any condition affecting the organs responsible for vitamin D activation. In addition, preventative measures include vitamin D supplementation during pregnancy and administering vitamin D drops to neonates and infants. Alright, as a quick recap, rickets and osteomalacia are conditions in which bone softening occurs due to a mineral deficiency or lack of vitamin D. Now, rickets presents in children, and osteomalacia happens in adults, which depends if there was growth plate closure. Some key symptoms of rickets are craniotabes and bow legs. For osteomalacia and rickets, the key symptoms are diffuse bone and joint pain, proximal muscle weakness, bone fragility, and increased risk of fractures with minimal trauma. There may also be looser zones on X-rays. The treatment typically involves oral vitamin D supplementation and treating the underlying cause.
Osteoporosis is a metabolic bone disease characterized by low bone density, decreased bone mass, and increased risk of fracture. Osteoporosis can be either primary or secondary. Primary osteoporosis is more common in postmenopausal patients, and it refers to bone loss that occurs with aging due to low levels of sex hormones, namely estrogen. Low estrogen levels cause increased osteoclastic activity, and since osteoclasts break down bone, this means increased bone resorption and, as a consequence, low bone density. Secondary osteoporosis, on the other hand, occurs because of an underlying cause, typically a medical condition like rheumatoid arthritis or a side effect of medications like glucocorticoids, especially when used for long periods of time. Osteoporosis is typically diagnosed using a dual-energy X-ray absorptiometry, or DEXA scan, and sometimes a FRAX score. Now, most patients with osteoporosis are asymptomatic, so perform a focused history and physical exam. When obtaining history, important risk factors include being postmenopausal, fracture history without major trauma, low BMI less than 20 kilograms per meter squared, osteopenia on imaging, a family history of osteoporosis or parental hip fracture, a history of smoking or excessive alcohol use, as well as medical conditions like rheumatoid arthritis, or the use of medications like long-term glucocorticoids. Finally, regardless of risk factors, you should screen all biological females over 65, biological males over 70, and individuals who are 5 years post-menopause should be screened for osteoporosis. Additionally, physical exam findings might reveal skeletal deformities, such as kyphosis or loss of height. Okay, now, if you suspect osteoporosis based on the patient's risk factors and physical exam, the next step is ordering a DEXA scan, which tests the patient's bone mineral density. A DEXA scan is typically performed at the hip and lumbar spine level. In patients with either known or suspected hyperparathyroidism, a DEXA scan of the distal third of the radius can be considered, as in these patients, bone loss tends to occur faster in the radius. Alright, now let's look at the possible results of our DEXA scan. DEXA scan results are typically reported as a T-score, which is a standard deviation measure of a patient's bone density compared to a reference population. Okay, now a T-score greater than or equal to minus 1.0 is normal. In other words, there's no osteoporosis, and you can consider alternate diagnosis. On the other hand, if the T-score is between minus 1.0 and minus 2.5, then the patient may have either osteopenia or osteoporosis, so you should use the fracture risk assessment tool to calculate a FRAX score. The FRAX score estimates a person's 10-year risk of either a hip fracture or a major osteoporotic fracture based on their age, sex, weight, height, and history of personal or parental fracture. It also takes into account smoking status, alcohol use, glucocorticoid use, history of rheumatoid arthritis, and bone mineral density at the femoral neck. If the FRAX score shows that the patient's 10-year risk is less than 3% for hip fracture and less than 20% for major fracture, then your patient has osteopenia. If this is the case, you should encourage lifestyle modifications, such as increased dietary calcium intake alongside vitamin D supplementation. Next, counsel your patient on smoking cessation, limiting alcohol intake, as well as weight-bearing, balance, and resistance exercises. If the patient is at increased risk of falling, you should refer them to a physical therapist. However, if the FRAX score reveals a 10-year risk equal to or greater than 3% for hip fracture and equal to or greater than 20% for major fracture, you can diagnose osteoporosis. Now, let's go one step back and check the DEXA scan one more time. If the T-score is minus 2.5 or lower, you can directly make the diagnosis of osteoporosis. Here's a clinical pearl to keep in mind. A fragility fracture is a break that occurs after a low-energy trauma, such as a fall from standing. The most common sites include the femoral neck, lumbar vertebra, and the radius. Any patient with a fragility fracture has osteoporosis, no matter what their DEXA scan or FRAX score shows, and might also need evaluation for underlying malignancy to rule out a pathologic fracture. Now that you've diagnosed your patient with osteoporosis, you should assess for secondary causes of osteoporosis. Vitamin D deficiency and chronic kidney disease can both cause osteoporosis. Next, review the patient's medication list and look for anything that can cause bone loss, such as long-term glucocorticoids, androgen deprivation therapy, and antiepileptic medications. Additionally, assess for endocrine disorders that cause osteoporosis, like hyperparathyroidism, hyper or hypothyroidism, hypercortisolism, as well as premature ovarian failure. Finally, evaluate for malnutrition or malabsorption conditions like celiac disease, inflammatory bowel disease, or a history of gastric bypass. Okay, now, if you've ruled out secondary causes of osteoporosis, in this case, you can diagnose primary osteoporosis, so management involves the same lifestyle modifications as well as pharmacologic therapy. Now, the mainstay of pharmacologic therapy in osteoporosis are bisphosphonates, so let's look at these drugs in greater detail. A key point to make when prescribing these medications is to tell your patients to avoid lying down for 30 to 60 minutes after taking the medication. This is because bisphosphonates can often cause or worsen esophageal disorders. Another thing to keep in mind is that because they can cause esophagitis, they shouldn't be prescribed to patients with esophageal disorders. Also, these medications should be used with caution in patients with chronic kidney disease, as they can worsen renal function. Some rare but serious side effects of bisphosphonates also include osteonecrosis of the jaw and atypical femoral stress fractures. To minimize this risk, stop treatment after 3 to 5 years to give your patient a temporary treatment break, which is also known as a drug holiday. Additional pharmacologic therapy options for osteoporosis include a RANKL inhibitor called denosumab, as well as parathyroid hormone-related analogs like teriparatide. Lastly, you can offer estrogen-related therapy to postmenopausal patients, but only if they can't tolerate these other medications, given its increased risk for deep vein thrombosis. Okay, so now that you've started your patient on pharmacologic therapy, assess their response to therapy after 1 year using DEXA scan. If the DEXA scan shows stable or improving bone mineral density and there are no new fractures, continue current management. However, if the DEXA scan reveals continued bone loss or there are new fractures, you should reassess for secondary causes of osteoporosis and consider alternative medication. All right, now let's go all the way back to our initial assessment for secondary causes of osteoporosis. Some important causes to look for include vitamin D deficiency, chronic kidney disease, certain medications, endocrine disorders, and malnutrition or malabsorption. If you do identify a secondary cause of osteoporosis, you can diagnose secondary osteoporosis. Management includes treating the secondary cause and encouraging the same lifestyle modifications. Lastly, if the patient continues to have bone loss despite this management, you should consider adding pharmacologic therapy. All right, as a quick recap, if you suspect osteoporosis based on history and physical exam, order a DEXA scan. A T-score of -1.0 or greater is normal. If the T-score is between -1.0 and -2.5, calculate a FRAX score. If it doesn't show a high risk of fracture, diagnose osteopenia and encourage lifestyle modifications, but if the FRAX score reveals a high risk of fracture, or the T-score is -2.5 or lower, diagnose osteoporosis. Then, evaluate for secondary causes. If there are none, it's primary osteoporosis, so start pharmacologic therapy. After 1 year, repeat the DEXA scan. If the bone density remains stable or improves, and there are no new fractures, continue treatment. However, if there's continued bone loss or new fractures, reassess for secondary causes, and consider switching to an alternative medication. Lastly, if there's an underlying cause, diagnose secondary osteoporosis. Management includes treating the secondary cause, lifestyle modifications, and sometimes pharmacologic therapy.
Osteo refers to bones, and porosis means pores. So, osteoporosis is when there's a higher breakdown of bone in comparison to the formation of new bone, which results in porous bones, meaning a decrease in bone density to the point of potential fracture. Looking at a cross-section of a bone, there's a hard external layer known as the cortical bone, and a soft internal layer of spongy bone, or trabecular bone, that is composed of trabeculi. The trabeculi are like a framework of beams that give structural support to the spongy bone. The cortical bone, in turn, is made up of many functional, pipe-like units called osteons, which run through the length of the bone. In the center of these osteons, there are hollow spaces called haversian canals, which contain the blood supply and innervation for the bone cells. Around the haversian canals, there are concentric lamellae, which look a bit like tree rings. The lamellae have an organic part, which is mostly collagen, and an inorganic part called hydroxyapatite, which is mostly calcium phosphate. In between neighboring lamellae, there are spaces called lacunae, which contain bone cells called osteocytes. At first glance, bone may appear inert and unchanging, but it's actually a very dynamic tissue. In fact, spongy bone is replaced every 3 to 4 years, and compact bone is replaced every 10 years, in a process called bone remodeling, which has 2 steps. Bone resorption, when specialized cells called osteoclasts break down bone, and bone formation, which is when another type of cells called osteoblasts form new bone. Bone remodeling as a whole is highly dependent on serum calcium levels, which in turn are kept in the normal range by a balance between parathyroid hormone, or PTH, calcitonin, and vitamin D. Parathyroid hormone is produced by the parathyroid glands in response to low serum calcium, and it increases bone resorption to release calcium into the bloodstream. On the other hand, calcitonin is produced by the thyroid gland in response to high serum calcium, so it opposes the action of PTH, therefore promoting bone formation and decreasing bone resorption. Finally, vitamin D promotes calcium absorption in the gut, so it increases serum calcium, promoting bone formation and decreasing bone resorption. The balance between these regulatory factors results in a peak bone mass, usually by age 20 to 29, and this usually occurs earlier in females than in males. Factors that determine the peak bone mass are genetics. For example, people of African descent tend to have greater bone mass, and nutrition, meaning adequate vitamin D intake increases bone peak mass. Finally, strength training increases peak bone mass, as well as hormones like estrogens and androgens that inhibit bone resorption. Okay, now when osteoclasts break down bone faster than the osteoblasts can rebuild it, it results in the lowering of the bone mass and eventually an osteoporosis. If we zoom into a cross-section of an osteoporotic bone, it will show normal cells with normal mineralization, which differentiates it from osteomalacia, where there's a lack of mineralization. So with osteoporosis, abnormal findings include fewer trabeculi in the spongy bone and thinning of the cortical bone, as well as the widening of the haversian canals. These bone changes increase the risk of fracture, and they're known as fragility or pathologic fractures. Some bones, like the vertebrae, shoulder blades, and ribs, consist mainly of spongy bone, so they're in great risk of fragility fractures. Factors that accelerate bone mass loss and increase the risk of osteoporosis are low estrogen levels, like after menopause, and low serum calcium. Additional factors include alcohol consumption, smoking, Drugs like glucocorticoids, which decrease calcium absorption from the gut through the antagonism of vitamin D, and drugs like heparin and L-thyroxine. Another factor is physical inactivity, as seen in astronauts in a zero-gravity environment where they just don't use their musculoskeletal system as hard as when they're on Earth. As a result, bone deposition decreases due to a lack of stress, while resorption increases. There are also diseases that can cause osteoporosis, like Turner syndrome, hyperprolactinemia, Klinefelter syndrome, Cushing syndrome, and diabetes mellitus. Now, the two most common types of osteoporosis are postmenopausal osteoporosis and senile osteoporosis. In postmenopausal osteoporosis, decreased estrogen levels lead to increased bone resorption. With senile osteoporosis, on the other hand, it's believed that osteoblasts just gradually lose the ability to form bone, while the osteoclasts keep doing their thing unabated. So, bone resorption usually overtakes bone formation around the 8th decade of life. People with osteoporosis don't usually have symptoms until a fracture occurs. The most common type of fractures are vertebral fractures, also known as compression fractures, and that occurs when one or more bones in the spine weaken and shatter. Vertebral fractures cause back pain, height loss, and a hunched posture. Femoral neck fractures and distal radius fractures can also occur, and they're often associated with postmenopausal osteoporosis. Osteoporosis is usually diagnosed with a dual-energy X-ray absorptiometry, or DEXA scan, which tests for bone density. The test compares an individual's bone density to that of a normal adult, which yields the result, or the T-score. A T-score less than or equal to negative 2.5 is diagnostic of osteoporosis. Treatment for osteoporosis usually relies on bisphosphonate drugs like alendronate and risendronate. If osteoporosis is really advanced, teriparatide, a recombinant parathyroid hormone, can be used. Now, even though parathyroid hormone stimulates bone resorption, it's been found that intermittent injections with teriparatide activates osteoblasts more than osteoclasts, therefore increasing bone formation. Interestingly, a thiazide diuretic like hydrochlorothiazide can be used to treat osteoporosis as well. Hydrochlorothiazide boosts calcium retention in the kidney and directly stimulates osteoblast differentiation, therefore decreasing mineral bone loss. Finally, medications like denosumab, which is a monoclonal antibody that inhibits osteoclasts, and raloxifene, which is a selective estrogen receptor modulator, can be used for postmenopausal osteoporosis. Alright, as a quick recap, osteoporosis refers to decreased bone density on account of increased bone resorption compared to bone formation. In osteoporosis, there's thinning of the cortical bone, widening of the Haversian canals, and a decrease in the number of trabeculi in the spongy bone. There are two common types of osteoporosis. These are senile osteoporosis and postmenopausal osteoporosis. The most common type of fracture in osteoporosis is a vertebral compression fracture. Diagnosis is done with a dual-energy X-ray absorptiometry, or DEXA scan, where a T-score equal to or less than negative 2.5 equals osteoporosis. First-line treatment relies on bisphosphonate drugs like alendronate and risendronate. Paget's disease of bone is a disorder in which there's a lot of bone remodeling that happens in some regions of the bone. Typically, there's excessive bone resorption followed by excessive bone growth, and that leads to skeletal deformities and potential fractures. Normally, bones undergo a continuous process of remodeling. Old brittle bone tissue gets reabsorbed by multinucleated bone cells called osteoclasts, which have 5 to 20 nuclei per cell. The resorbed bone tissue gets replaced by a new one made by another type of bone cell called an osteoblast. At the cellular level, the process begins when osteoblasts release receptor activator of nuclear factor kappa beta ligand, or RANK-L for short. which is a substance that binds to rank receptors on the surface of an osteoclast. When rank L binds to the rank receptor, it activates the osteoclasts, and they start secreting lysosomal enzymes like collagenase as well as hydrochloric acid. Together, they digest the collagen protein and dissolve the minerals that make up the bone matrix. Once there's been sufficient bone demineralization, the osteoblasts secrete another substance called osteoprotegerin, or OPG for short, which binds rank L and prevents it from activating the rank receptors. This causes the osteoclasts to stop demineralizing the bones. Once that happens, the osteoblasts start secreting a substance called osteoid seam, which is mainly made up of collagen and acts like a scaffold upon which calcium and phosphate can get deposited. And that's how new bone begins to get formed again. The exact cause of Paget's disease of bone is unclear, but it can get triggered by infections like the measles virus and is linked to genetic mutations like the SQSTM1 mutation, which encodes a protein involved in regulating osteoclasts. When Paget's disease of bone occurs, it can affect a single bone or the whole skeletal system. Most often, it involves the skull, lumbar vertebrae, the pelvis, and the femur. Now, there are three main phases to the disease. Phase 1 is the lytic phase, and that's where osteoclasts which have up to 100 nuclei start to aggressively demineralize the bone up to 20 times more than normal. Phase 2 is the mixed phase, and that's where the lytic phase occurs alongside the blastic phase. In the blastic phase, there's a rapid but relatively disorganized proliferation of new bone tissue by an unusually large number of osteoblasts. The result is that collagen fibers are deposited in a haphazard way. Phase 3 is the sclerotic phase, and that's where new bone formation exceeds bone resorption. And the final result is bone that's structurally disorganized and therefore weaker than normal, healthy bone. Eventually, the osteoblastic activity also slows down, and there's a dormant state in the disease, called the burned out state. Early on, Paget's disease of bone doesn't typically cause symptoms, but over time, the misshapen bones can impinge on nerves and cause pain. In addition, if the skull is involved, the overgrowth of bones can make a person have a lion-like face, which is called leontiasis. The bony overgrowth can also narrow the auditory foramen and impinge on the auditory nerve, leading to hearing loss. If there's bony overgrowth that impinges on the optic nerve as it passes through the optic canal, that can lead to vision loss. Sometimes the accelerated bony growth can lead to genetic mutations that cause a bone cancer called osteosarcoma. When that happens, it's referred to as Paget's sarcoma. Other bony deformities from Paget's disease of bone include kyphosis, which is an excessive curvature of the spine, making a person face down to the ground, lower limb muscle weakness from misshapen vertebrae compressing the spinal cord, and pelvic asymmetry. It can even lead to bow legs if the tibias and femurs get too weak to support a person's weight and begin to bend over time. If the parts of the bone that are involved in a joint become affected, it can result in arthritis or joint inflammation. The diagnosis of Paget's disease of bone is usually done by checking for elevated levels of alkaline phosphatase. In addition, an X-ray might show lytic lesions during the lytic phase of the disease, or thickened bone cortices in advanced cases. Finally, a bone biopsy is usually done to exclude malignancies, which can mimic some of the findings of Paget's disease of bone. Treatment of Paget's disease of bone includes pain relievers as well as anti-resorptive medications like bisphosphonates, which slow down the bone lysis. In addition, surgery can help correct bone deformities, decompress an impinged nerve, and reduce associated fractures. Alright, as a quick recap. In Paget's disease of bone, there's an excessive amount of bone resorption and haphazard bone growth. There's a lytic phase, a mixed phase with both a lytic and blastic component, and a sclerotic phase, which results in weak bones. Paget's disease of bone is usually asymptomatic, but can result in weak, misshapen bones that cause fractures and lead to nerve compression. Learn medical knowledge more efficiently with Osmosis Prime, the one-stop shop for exclusive videos, personalized study schedules, practice questions, flashcards, and more. Sign up for a free 2-week trial today at osmosis.org/free trial.